Hypertension is one of the most important topics on the entire UKMLA. It touches cardiology, renal medicine, endocrinology, pharmacology, as well as primary care questions, and is therefore likely to be a topic that could come up on examinations. For today, we'll be covering background information, the pathophysiology behind raised blood pressure, how it is diagnosed and staged, its clinical presentation, the relevant investigations, the full management algorithm across all 4 steps, as well as the monitoring and blood pressure targets. Hypertension affects around 1 in 4 adults in the UK and is the single biggest modifiable risk factor for stroke, myocardial infarction, heart failure, as well as chronic kidney disease. It is often called a silent condition because most patients have no symptoms at all until end organ damage has already started, which is exactly why opportunistic screening in primary care matters so much. By definition, hypertension is a persistently elevated blood pressure confirmed with ambulatory or home monitoring after an initial raised clinic reading. A single high reading in clinic is never enough to diagnose someone because clinic readings are notoriously unreliable. This brings in a concept that examiners love to test, white-coat hypertension, where clinic readings are high but home or ambulatory readings are normal. Around 90 to 95% of cases are primary or essential hypertension, meaning there is no single identifiable cause. It is thought to develop from a combination of genetic predispositions, age-related arterial stiffening, and a lifestyle factor, which includes high salt intake, obesity, alcohol, and inactivity. The remaining 5 to 10 is caused by secondary hypertension. Renal disease, particularly renal artery stenosis and chronic kidney disease, are very common secondary causes of hypertension. There are also endocrine causes such as Conn syndrome, also known as primary hyperaldosteronism, which presents with hypertension and hypokalemia. Pheochromocytoma is another cause, and it causes episodic hypertension with palpitations, headache, and a headache. There's also pregnancy-related hypertension, and that includes preeclampsia, and that is managed on a separate NICE guideline. So don't confuse the two in a question that specifies a pregnant patient. To understand why the drug classes work the way they do, you need to understand the underlying physiology as much as possible. Blood pressure is simply cardiac output multiplied by peripheral vascular resistance, so anything that increases either of those raises your blood pressure. The renin-angiotensin-aldosterone system, or the RAS system, sits at the center of all of this. When renal perfusion drops, the kidneys release renin, which converts angiotensinogen to angiotensin 1, and this is then converted to angiotensin 2 by ACE. Angiotensin 2 is a potent vasoconstrictor, and it also triggers aldosterone release from the adrenal cortex, which drives sodium and water retention, expanding circulatory volume. This is precisely why ACE inhibitors and angiotensin receptor blockers are phase-line drugs in young patients, because they interrupt this pathway directly. Alongside RAS, sympathetic nervous system overactivity increases heart rate and vascular tone. Endothelial dysfunction reduces nitric oxide-mediated vasodilation, and with age, the arterial walls stiffen and lose their normal compliance, which raises systolic pressure in particular. The consequence of all of this, if left untreated, is chronic damage to the organs that are most sensitive to pressure and flow. In the heart, sustained afterflow causes left ventricular hypertrophy, which can progress to heart failure, and it accelerates ischemic heart disease. In the brain, hypertension is the leading risk factor for both ischemic and hemorrhagic stroke, as well as vascular dementia. In the kidneys, high pressures damage the glomeruli over time, causing hypertensive nephropathy and progressive chronic kidney disease, which in turn worsens the hypertension, a vicious cycle that is difficult to break. In the eyes, you can get hypertensive retinopathy, and fundoscopy findings are also very frequently displayed in an exam setting. NICE defines 3 stages for hypertension. Stage 1 is a clinic reading of 140/90 or higher, confirmed with an ambulatory reading or a home average reading of 135/85 or higher. Stage 2 is a clinic reading of 160/100 or higher, confirmed with an ambulatory or home average of 150/95 or higher. Severe hypertension is a clinic systolic of 180 or higher, or a diastolic of 120 or higher, and this is managed differently because of the immediate risk involved. Severe hypertension needs urgent same-day specialist assessments if there are signs of particularly retinal hemorrhage or papilledema, life-threatening symptoms such as new confusion, chest pain, signs of heart failure, or acute kidney injury. For ambulatory blood pressure monitoring, NICE specifies at least 2 measurements per hour during the patient's usual waking hours, and the diagnosis is confirmed using the average of at least 14 readings. If a patient cannot tolerate ABPM, home blood pressure monitoring is the acceptable alternative, and this is also worth knowing as a step up in the recent update to this guideline, which now places more emphasis on out-of-clinic monitoring in general. Most patients with hypertension are completely asymptomatic, which is exactly why hypertension is picked up incidentally on routine screening far more than through a patient presenting with symptoms. If symptoms do occur, a headache, classically occipital and worsening in the morning, is the most commonly described, as long as some visual disturbance. Beyond that, symptoms usually only appear once end organ damage has developed, or in a hypertensive emergency where chest pain, breathlessness, and confusion can occur. On examination, most patients have no abnormal findings. Radiofemoral delay should make you think of coarctation, and a renal bruit should raise suspicion of a renal artery stenosis. Fundoscopy may reveal hypertensive retinopathy in a long-standing disease. Investigations fall into 4 groups. Confirming the diagnosis itself uses clinic BP measurements in both arms, since a significant difference between the arms can suggest vascular disease, followed by ABPM or HBPM as we discussed. Bloods should include U&Es and eGFR to assess renal function, because this both screens for a renal cause and establishes a baseline before starting an ACE inhibitor or an ARB, alongside with HbA1c and lipids to complete overall cardiovascular risk assessment. If Conn's syndrome is suspected, a renin to aldosterone ratio is the key test. Screening for target organ damage involves a urine albumin to creatinine ratio to look for proteinuria, a urine dipstick for hematuria, and a 12-lead ECG for voltage criteria of left ventricular hypertrophy. A fundoscopy to look for retinopathy can also be performed. Finally, cardiovascular risk is calculated using the QRISK-3 score, alongside a fasting glucose to screen for undiagnosed diabetes, since the two conditions frequently coexist and compound each other's risks. Drug treatment for hypertension is guided by age and ethnicity. In patients under 55 who are not Black African or African Caribbean origin, step 1 is an ACE inhibitor or an ARB, reflecting in the RAS-driven physiology typical for this group. In patients 55 or older, or of Black African and African Caribbean origin at any age, step 1 is a calcium channel blocker instead. When you're starting an ACE inhibitor, remember to check U&Es before and roughly 2 to 4 weeks after starting, watching for a rise in creatinine or potassium, and warn patients about the classic dry cough side effect that often prompts switching to an ARB. Calcium channel blockers commonly cause ankle edema, flushes, and headaches, which is worth mentioning to patients up front so they aren't caught off guard. If the target isn't reached on a single agent, step 2 adds a second drug from a different class. This gives you the combination that underpins the whole algorithm, often remembered as ACD, an ACE inhibitor or angiotensin receptor blocker, combined with either a calcium channel blocker or a thiazide diuretic such as indapamide. Step 3 therapy is triple therapy, combining all 3, A, C, and D together. And then there's step 4, and NICE is explicit that you should first confirm this is a really resistant hypertension, meaning you should check the patient is actually taking their medication, confirm the elevated reading out of clinic, and rule out postural hypertension as a contributing factor. Step 4 is where potassium becomes the deciding factor, and this is one of the most commonly tested points. If potassium is 4.5 millimoles per liter or below, add a low-dose spironolactone. If potassium is above 4.5, avoid spironolactone due to the risk of dangerous hyperkalemia, and instead consider an alpha blocker or a beta blocker. Spironolactone itself can cause gynecomastia in men, which is worth knowing as a counseling point, and alpha blockers carry a real risk of postural hypertension, especially in the older group. If blood pressure remains uncontrolled even on 4 drugs, this warrants specialist referral for further workup. Once a patient is established on treatment and the blood pressure is stable, NICE recommends an annual review to check control, reinforce lifestyle advice, and screen for medication side effects. It's worth remembering the target ranges because they differ by certain populations, as you can see on the video here. Lifestyle measures remain relevant throughout treatment and not just at diagnosis. Reducing sodium intake, limiting caffeine and alcohol intake, regular exercise, weight loss where appropriate, and smoking cessation all meaningfully contribute to blood pressure control alongside medication. It's always worth remembering that even a single severe range reading, regardless of how well controlled a patient has been previously, needs urgent same-day assessment rather than being managed routinely at the next scheduled review. That covers everything you need to know on hypertension, from diagnosis and staging through to the complete 4-step management plan. If this helps you with your revision, please consider liking and subscribing. It really helps the channel reach more students preparing for exams. If you have any questions, leave them down in the comments, and thank you so much for watching.